right, everybody. Thanks for bearing with us there for a few minutes. Glad to have all of you joining us today. We're excited today to talk about aging voice. You're here for your voices telling on you treatments for an aging voice. We have two experts in the field joining us today, Dr. Edie Hapner, who is the co-director of the UAB Voice Center. She is a speech pathologist, and then Dr. Blake Simpson, who is the other co-director of the UAB Voice Center, who is a laryngologist. My name is Quinn. I'm the clinical fellow here at the UAB Voice Center this year, so I'm very glad to have you all here. What we would like is if people could place questions in the chat. We had a variety of questions pre-submitted, but if questions come up, rather than raising our hands, we're going to do in the chat, and I have somebody monitoring the chat here with me. So we will do that, and we're just going to let Dr. Hapner and Dr. Simpson share their wealth of knowledge with us. So,
hey Quinn, can you hear me okay?
Yep, I can hear you. Blake, do you mind doing a little test?
Yep. Hello. My
Beautiful. Perfect.
Okay.
Yeah.
So we're going to start out with the basics. And Dr. Simpson, we're lobbing this one to you, but what is aging voice? Just give us some details.
Well, it's funny because if you had asked me this question before I worked with Dr. Hapner, I might have given you a slightly different answer. So, because everybody learns from Edie if they're around her.
Oh, stop.
But I think the short answer, of course, is the changes in the vocal cords themselves and the voice box itself. And we lose 1% muscle mass in our bodies every year, starting after about age 50. And that vocal cords are mostly made up of muscle. So it is no different from the other muscles in that you're going to get some loss of that as you get older. So the vocal cords thin out, and that's going to result in a more thin, reedy voice. It's true for men and women both. I think we tend to see men affected by it a little bit more, and Edie may feel differently on that. She knows the demographics better than I do, but what I've learned from her, which is quite important, is the respiratory drive also. As we get older, it's just not there to the same degree as it was before. And that's the bellows, that's the air source for our vocal cords. So if you take a hit by having slightly more thin vocal cords and you add in this respiratory challenge, respiratory reduction as you get older, those two combined, I think, to create a problem. And the other thing about aging voice, I think, is that the less you use it, the more likely you are to have these problems. So the use it or lose it thing, also I've learned from Dr. Hapner, seems to hold true. So even if there's any falsehoods in there.
No, I think that was a great answer. I think that men and women present differently, right, in aging voice, and happens a little earlier in women because it generally starts to show up right after menopause. But early on in women, the vocal folds get swollen because of hormonal changes. So women complain of a lower pitch in their voice, where men, they are consistently complaining that they are confused for women on the, when they answer the phone or something else, because they lose muscle mass and then their pitch gets higher. But I think it all evens out, around 73 to 75 and starts to thin out. Hey, Quinn, are there actual slides, or is this the only one?
This is the only one.
So maybe we could do it where the three of, I don't know if there's a way to do that.
Yeah, the three of us are all pinned, so we should be at the top of everyone's view as long as people have their thumbnails open.
Okay. So maybe I don't have my thumbnail open.
I had Kevin check it for me, and he can see all three of us. So
perfect.
I would say, as a corollary, it's important to note, and we see this a lot, that when somebody presents, if it's a male or female that presents who had no difficulties with their voice for their entire life, and suddenly this starts happening in somewhere in the 70s, it's almost always related to aging voice. I would say, the whole notion of, is this reflux? Could there be polyps, nodules? You just don't see that in that population. It's usually either vocal fold atrophy, aging voice, or vocal tremor, something like that.
Yeah.
So it's just such a common thing. Almost like if we see their demographics, their age, we know what their complaints are going to be a lot of times, because they're related to aging voice 99% of the time.
I would say that for anybody that's on this call that is not a medical person, though, that's really important. Aging voice is a diagnosis of exclusion, something we say in medicine. And what that means is that we have to look at your vocal cords and make sure that it indeed is, the problems that you're having are indeed because of changes to the mass of the vocal folds, that there's not something growing on them, not like nodules, like Dr. Simpson said, right? Not like nodules, because as we get older, we don't have those lesions on our vocal folds from doing too much. You know, everybody thinks that the answer to everything is voice rest, but as we get older, voice rest is the worst thing you can do. So make sure that you don't just blame it on aging voice. That was, I think, Dr. Simpson, that was more for our medical people, right? Like it's aging.
That's right. That was, I saw Dr. Anderson there and I was like, another ENT, a nice ENT who's smart. Yeah.
Yeah.
But yeah, that's as a general advice to the population, I would say that's not good advice. Yeah, if you're hoarse, it needs to be investigated. But I think a lot of times we see people that have already been looked at.
Yeah.
And they had a scope and sort of the bad things have been eliminated. And then it's a matter of using sort of the technology we have at our voice center that other people don't have access to look and see how their vocal cords are closing. These are things you can't see with just a regular, lighted scope that's through the nose. And so we have the technology there to help figure out if that's the problem that's going on. And often it is, the vocal cords are thinned out and not closing very well. But a very good point, Edie.
Awesome. Thank you, guys. And you guys have already touched a little bit on this, Edie. You mentioned it specifically, but what are the things people can look out for symptom-wise that they may notice about their voice that's indicating to them that, oh, maybe this is something that's happening to me. My voice is changing.
Well, I think I said before, change in pitch often is some of the first signs, but really, women a little lower, men a little bit higher, but really the thing that people complain about the most is a loss of loudness, a loss of power, and feeling like they have to push so much harder to be heard. And, it comes at the worst time in our lives, right? Because many of our friends, along with aging changes to the larynx, have aging changes to hearing. And so it's harder to hear someone speak. And so we're always wanting people to speak up. And so some of those first changes are really like, I'm having trouble communicating in noise like a restaurant, or communicating with my friends. And I'm just so tired after I talk. It just wears me out.
Absolutely love that. So let's not leave people on a cliffhanger. We're telling them, oh, this is something that could happen as you get older. So I want you to start. Actually, I think, Dr. Hapner, I want you to start. What are some of our behavioral treatments for aging voice?
Oh, so behavioral meaning not surgical or procedural or a medication. So there is a lot of good evidence out there for the use of, and I'm going to be real specific about this, exuberant voice therapy. So voice therapy is not voice therapy is not voice therapy, meaning, people come in and they say, oh, I had voice therapy and it didn't work. It really is a very specific type of voice therapy that builds up your respiratory system and builds up your larynx. It's not the same therapy that we use for nodules, polyps, or cysts earlier in life. So voice therapy is good. Talking is good. Don't stop talking. Everybody wants to stop talking to fix their voice. Talk more. Call the dog. Talk loud. And singing is probably, get involved with karaoke or a community choir or a religious choir or something, because singing is one of the best vocal exercises.
Absolutely love that. And on the flip side of that coin, I know often we approach first with behavioral therapy if it's indicated, but we also have several different medical options. So Dr. Simpson, if you could talk a bit about those.
Yeah, so I would say and this is the nice thing about working with our speech language pathologists, and they see our patients with us for every new patient with us. is to get sort of their analysis of how stimulable they are. And by that, I mean, how likely is voice therapy to work? And there's a great testing that we do right here in clinic that can give us an idea of whether they're going to respond to voice therapy as the primary mode, which is usually the answer. More often than not, voice therapy is the thing that's going to take care of the problem. But if the thinning of the vocal cords is severe enough, it may be that the therapy is not really the best option and they need a little bit of help, we say. And that basically means we need to build up their vocal cords a little bit, because these thin vocal cords can be injected with a filler. And these are the same kind of fillers that you would use for wrinkles or lips to, plump up lips. It's the same kind of material. So it lasts, a few months and it plumps up their vocal cords. They usually go to voice therapy after that. And although it's a temporary treatment, considered a temporary treatment, I've been amazed how often that these patients get long-term results from a combination of injection first, injection with a bulking agent, followed by voice therapy. I kept thinking I was going to have all these patients that needed a thyroplasty, a little implant surgery that's the more permanent version of the injection, and very few of them needed it. And I think there's something to be said for this, not just as a standalone therapy, voice therapy, but as a adjunct to their or injection, or maybe I'm the adjunct and I just don't realize it yet. But I've been really impressed with how well this works. And the interesting thing is, just for the people who are listening to this, is I worked in Dr. Hapner and I have only worked together for 5 years.
I know.
And before that, we were in separate voice centers. She was in California, I was in Texas. And I was not getting the results. I mean, we have a good speech pathologist, but not getting the results with this Forte program that Dr. Hapner invented for this condition. And then I got here, and all these patients were getting better. And I thought, it's the therapist, it's the program, right? It's somebody who's been trained in this and knows how to do it. And that's been a game changer for me. And actually, I'm not as surgically as busy because they've worked. That's right. No, it's good. They've been able to work with these patients without the need for any intervention. And we love doing these. They're great surgeries. They can change people's lives, but oftentimes that's not what's needed. But we're there for the more severe cases. And again, the injection I mentioned would be considered temporary. We often do that in a clinic setting, but we can also go to the operating room and inject. And like I said, if that wears up and they need additional, we can put implants in at a later date. So we've got the short-term and long-term solutions, but voice therapy works so often that's really been our mainstay.
Awesome. Thank you. So one thing, it's amazing that we have all these different treatment options, but I know lots of times people are concerned about if insurance will cover this. So Dr. Simpson, why don't you go ahead and speak to that?
Yeah, so I've practiced in 2 different locations, and I've never had any problem with third-party insurance or Medicare getting this approved, because it's a recognized condition. We have, doctors have known, we call them codes, which would be the name of the diagnosis that is associated with these different treatments. And it's well acknowledged by Medicare and the third-party payers that this is a medical condition. It's not something that's, cosmetic, so to speak. It's a medical condition that has medical treatments that are approved for it. So we just haven't seen that. And has that been your experience as well, Edie?
Yeah. What's really interesting is Medicare, which many people that, come in for Aging Voice are rightly so on Medicare. Medicare has kind of this blanket approval for 40 therapy sessions a year. Now, there's a caveat. They make us split the money that they put in this pot for those sessions with physical therapy. So if you ever go see a speech pathologist and you're on Medicare, or you go see a physical therapist, make sure you tell them you're getting the other therapy. But 40 sessions, oh my gosh, I bet I could ask Quinn this same question, and I would say to you that voice therapy for aging voice at most would require 1 session a week for 4 weeks, and then maybe 1 to 2 sessions the second month. So we're talking 6 therapy sessions overall. And I got to be honest with you, the majority of people get 4 or less therapy sessions. So the idea that you need 40 therapy sessions, or you need to come in 2 or 3 times a week for this very, for voice building is what we call it, or exuberant therapy for aging voice, it's really not necessary. It's just not.
Awesome. Thank you. So I want to touch on a couple other things that we know can impact voice or kind of live in the same region. First, I want to talk a little bit about pulmonary status and how that can impact voice. You know, we had some questions asking, will other things like asthma or COPD, could that be impacting my voice? Dr. Hapner, I'll let you start with that one.
So there were some really interesting studies that came out of Spain that pretty much changed my life around 2015, 2016 by a group that looked at a large number of people with aging voice. And believe it or not, they found that more people had reduced respiratory support who came in with those complaints of, oh, my voice is tired, it's fatigued, the pitch is changing, I can't get louder. So, and everything, you know, and their vocal cords actually looked pretty good. So there is a huge component of respiratory support in aging voice and in anything we do as we age. So when we do voice therapy for aging voice, we put together a complement of treatment for the larynx, that exuberant therapy, and treatment for the respiratory system, a very specific type of inspiratory muscle strength training. Inspiratory, not expiratory. Okay?
Awesome. Great. And again, kind of living in the same region, Dr. Simpson, are there changes that can happen to your swallowing as well as we age?
Oh, absolutely. It's one of the most, it's amazing that we can swallow. Just the coordination between the muscle groups. For that to happen, to bring food down, it's quite extraordinary. And I will say, just it's funny now. I can speak about senescent changes now because I've lived them. So you know, aging is my middle name. So I can even tell you too that my coordination of my swallow is not as good as it is now. It was much better when I was in my 40s. I aspirate, you know, liquids go down the wrong way, make me cough and choke much more often than it did before. So just a lack of coordination would be enough to impair your swallow, not to mention, you know, muscle loss as we get older. So the pharynx, you know, the back of the throat's not going to contract as well. The systems just break down. And when you have a system that's involving so many different muscle groups, you can only imagine it's going to take one or two, you know, hits in there to really put you off with swallowing. So definitely aging and swallowing difficulties are commonly linked, probably more so even than voice, I would say, or at least as much as. So that is definitely a factor.
Absolutely.
Hey, can I say this?
Oh, yeah, go for it, please.
So it's really interesting. It goes back about 40 years because I'm speaking of aging as my middle name. But there was a very interesting study looking at like 80 to 90-year-olds and who had some real impairment in swallowing and were choking on food and reduced tongue strength. And why that's so important is the very last thing that we want anyone in their 80s or 90s to have to deal with is aspiration pneumonia. So we don't want food going down the wrong way into your lungs. And they did some therapeutic tongue strengthening exercises and found that even, I mean, the human body is so amazing, right? That even in 80 and 90-year-olds, that there could be a significant improvement in swallowing safety and comfort in no matter how old we are. So if you're having problems with your swallowing, please be seen. It's not all reflux. It's not all, you know, even if it is because of aging changes, there are therapeutic things we can do, primarily a speech pathologist, but you should see an otolaryngologist for sure first. But there are therapeutic things we can do no matter how old you are to help with that. And it's really important, maybe life-saving.
Absolutely.
Indeed.
Absolutely. So we had a question in the chat for Dr. Simpson, and I know this is one that we talk about in clinic too, but Dr. Simpson, wondering if you have any more detail or thoughts about why we sometimes see that after injection augmentation, people don't need a repeat injection, even though, you know, we're not exactly sure why.
Yeah, it's interesting you asked me that question because we just had there's a There's a meeting called Advanced or Controversies in Laryngology that we have in Chicago every year, and it's only people that have been laryngologists, 10, 20 years. And this very subject came up about how this happens. And interestingly, 50 brilliant minds in the room, no one really had a great explanation for that. So I feel like I'm not completely, maybe Hapner had been there, she would be able to answer it. But I do think there's something they're able to get it a little bit easier, I think, if they've had their vocal cords injected, and there must be some benefit that has to how much the therapy kind of takes, I guess. I'm hand waving because this is hard for me to explain, but I do think there's an advantage. I mean, we've never looked at it with research, but I'm positive there's definitely an advantage to having a therapy soon after the injection to take advantage of the fact that there's now better closure. Edie, do you have a reason you think this works?
It's interesting. They found in people people that have these complaints about aging voice tend to do just the opposite of what we want them to do, and that is to talk less because they're tired. It's more work. Some people complain of coughing along with it or pain. But there's a study that was published that said that after voice therapy, these people with aging voice tend to talk more because it's easier. And I wonder, Blake and Quinn, if that's what's happening with, at least in aging voice, with injection too. So you go to an otolaryngologist, a laryngologist, you have your vocal folds injected, it's now easier to talk, you can talk louder, you can socialize more. And I wonder just the act of using the mechanism, if that has something to do with improving overall status that is lasting when we know the injectable's gone.
It has to be, yeah. That actually makes good sense. They finally have a good period of time where they can really harness it, and by then they bought into it.
Yeah.
Totally interesting. Love that. Okay, another question in the chat, and this is one we get all the time from patients. Do various foods, particularly foods that are spicy or acidic or carbonated, have a long-term effect on the human voice? And I'm reading into it a little bit, but maybe secondary to reflux.
Dr. Simpson, this is all yours.
Yeah, I feel like this is partially our fault as laryngologists. I think there was a connection that was drawn between acid reflux and changes in the voice. And there's a good colleague of mine, Jamie Kaufman, that kind of put out this paper, I mean, it's probably been 40 years ago, showing the connection between voice problems, or voice box problems, if you will, in a broad sense, and reflux. And there was sort of connection being drawn between the two. And I think we bought into it, and a lot of us did research in that area, and it seemed to be pointing that direction. But, I think the longer time has gone by and the more research we've looked into with this, and I'm not saying reflux doesn't affect your voice. Of course, I think it can. But as a long-term problem that results in permanent voice changes, I really don't see that. If we're talking specifically about voice, airway could be a little different. But I think that the connection that's being drawn between those two has been really largely erased in many senses since then. It's our fault for kind of putting it out there. I think we're all big believers in it. And the more I think we've investigated this, and the research in laryngology has gotten so much better, you've got to admit, Edie, in the last 20, 30 years.
100%. Yeah.
I think we're just discovering some of the stuff we were just wrong about. And so, again, not saying that reflux can't affect the voice, especially in temporary short-term situations, if you have acid coming up and splashing in your vocal cords. But if that condition's treated or if it's infrequent, I think the chance of that leading to any voice difficulties that are long-term is almost zero. I think it'd be quite rare.
Awesome, thank you. Here's another question in the chat. I'm loving the questions in the chat, so keep sending them. Edie, I'll ask you this one, but in aging voice, can consistent throat pain be a symptom?
Well, I have to say first and foremost, if you have consistent throat pain, please go to an otolaryngologist to look at your vocal folds and to examine you and to feel your neck. Your primary care doctor can't do that. Your allergist can't really do that. You need to go to an otolaryngologist and rule out that it's not something else. But if they do rule that out and they do say, ooh, it sounds like some signs of aging voice, the more you have to work and use extra muscles in your throat, in your chest. Some people even use them in the back, in the upper back and shoulders to get voice out, to talk louder. Let's say you work in a call center, or you're a teacher, or you have a hearing impaired significant other, or that you're taking care of. The more you have to do that, the more likely it is that you're going to have just secondary muscle pain. There's even a name for it. It's called delayed onset muscle soreness. And it's the same kind of pain that you get when you go to the gym, or you go to an exercise class and you work out too hard, or you work out too long, or you haven't done it in a while, and your muscles hurt the next day. So imagine if you're constantly talking like you're working out too hard. Yeah, pain could be associated with it. And the way to get rid of that pain, first get them looked at, and then second, we got to get rid of the cause of the pain. And if the cause of the pain is an underlying presbyphonia, then as Dr. Simpson said, if it's too severe, to be honest with you guys, even if it's moderately severe or severe case of thinning, we need help from our otolaryngology colleagues to plump up your vocal folds. If it's very mild, we can do therapy.
Wonderful, thank you. So I want to, we've covered a lot what aging voice can look like, the etiology of aging voice, other things that can happen as we age, like your pulmonary system and swallowing. I wanted to talk a little bit about what we do every day and what we can provide here at the UAB Voice Center. So for those who don't know, Dr. Simpson, what is the UAB Voice Center?
Well, UAB Voice Center, basically, we started this together. Edie and I have been friends forever. Mm-hmm. And it was bringing her from California, me to Texas, to kind of just start this anew. There was a good history of just excellent otolaryngology care here in Birmingham at UAB, and to our private practitioners around the state. And I think this department needed a restart on the Voice Center. And so they brought in 2 new people to do this. They didn't know what they were going to get into. But it was basically started 5 years ago with a promise from the institution they would support us to the degree we needed support. And we of course asked for a lot, because we wanted to make a voice center that was better than any other voice center in the country. So that's what we set out to do. And I guess we started out kind of just me and Edie, right? It was just Edie and I. And then we both got fellowship training programs started pretty much immediately. So we both had trainees, you being one, a superb one, by the way, Quinn. We're going to miss you. And then a laryngology MD fellow. And then shortly after that, we got a PA. Mm-hmm. And then Edie hired a army of superb speech language pathologists. I think we have 7 or 8, not only voice, but airway, swallowing, the whole gamut of care. So it's basically what our vision was, and what we've been able to do is we believe in seeing patients as a team. So interprofessional care is kind of the first official term. But if you come to see us at the Voice Center, you're going to be seen by usually 3 people in the room. So it's usually an MD, a speech pathologist, and then one of our fellows that's in the room. So the care is very much done as a team. The patients appreciate, they buy into it. I think they realize, hey, this may not be a surgical solution. This may be more for the speech pathologist. Maybe it's a combined. Maybe they need both of us to help them with their voice. But that was really what we set out to do. And I'm happy to say, that's really the way the clinic runs. We're big believers in it, and I think our patients buy into it as well. But it's the full spectrum of voice, swallowing, and airway disorders that you would see at many voice centers in the country. It's more than just about the voice, as we've been talking about. But that's my shortish version about UAB Voice Center. I think it's been very meaningful. We talk about this as our terminal career, our terminal jobs, because we don't intend to going anywhere until we retire. So it's been a great run, and the institution's been fantastic.
Love it. Kind of more practically, how can people get an appointment here at the UAB Voice Center? Dr. Hapner, I'll let you go.
Well, I would say the normal way. You can call our access center. Maybe we can put the phone number up at some point and request to be seen specifically at the UAB Voice Center. And they're going to ask you, a bunch of questions to make sure that voice swallowing or airway issues are really your problem. And if not, they might suggest you see someone else. I will tell you that Dr. Simpson and I apologize for any delays that anyone has had on this call in getting an appointment, because as I have always said, if you build it, they will come, and people in the state of Alabama, Mississippi, Georgia, Florida have really been very supportive, and we really appreciate it. We just hired a new laryngologist, fellowship-trained laryngologist, who will be starting October 1st. So hopefully that will really help with getting in. It's a good time to call for an appointment. She hasn't started yet, so she's not busy. But, if you already see a speech pathologist or an otolaryngologist for other reasons and they don't want to work with you on voice, I think we try really hard to have good relationships with physicians and speech pathologists around the Southeast, and we do a lot of sharing. If we have a patient who lives closer to one of our colleagues, we'll say, don't drive this far. Yeah, I'm always happy to see anyone.
Awesome.
Yeah, I think generally you need a referral from another MD. I think it's the way it's done, and generally it's been from, at least in my case, from one of my colleagues who's an otolaryngologist in the state, who have, I think all of them have my phone number, and if they're on this line, you can text me anytime. But and we work patients in for that reason. But usually it's an MD referral is necessary, to just for access issues. But I think, yeah, our wait times should go down significantly when Dr. Perryman starts, and that should be a good building of the Voice Center. We need to build the MD part of it. We continue to do that. So I think this will get our access much, much better.
Yeah, totally. Wonderful. So along that same line, Dr. Hapner, what can patients expect when they come in for a voice evaluation?
What a great question. So, when you come to the Voice Center, we're going to ask you to fill out some paperwork about the history of your voice problems, what you've done, and then we're going to ask you to fill out validated tools that we call patient-reported outcome measures, and it's really a push in all of medicine around the world, I'm going to say, to make sure that we understand the impact of your problem on your life, on your home life, your career, your social life, and overall. Because it's important. People sometimes come in and apologize to us, and they're like, "Well, I'm not a singer." No, you don't have to be a singer. Anybody is welcome, and we actually call anybody who sings, even if it's in the shower, a singer. So everyone's welcome. You'll fill out those forms, then you'll come back to our clinic where you'll see generally a speech pathologist and our PA or one of our fellows, who is actually somebody who has finished medical school, finished their residency, and are coming for advanced training. And we'll ask you a lot of questions about your voice problem, and we'll listen to your voice or your swallowing problem or cough, right? That's another one. We see a lot of people with problems with cough. We see a lot of people with Parkinson's disease, and we can talk about that a little bit too also, Quinn. But Parkinson's disease, laryngeal dystonias, a lot of those. So we're going to ask you a lot of questions. Then we're going to take a look at your vocal folds. Now, people get really nervous about this exam, but I promise you, one, we generally numb you up, so it's a little more comfortable. We have a lot of practice in doing these exams. I hate to admit to you how many years I've been doing this. Dr. Simpson, you don't have to admit that one either, but we've had a lot of practice, and we really pride ourselves in doing the kind of exams that don't hurt anyone. then after the exam, we will show you the exam, we will explain the exam to you, and then in all likelihood, the next set of words we're going to go out and we're going to have a talk with Dr. Simpson, fill him in on what you told us and what we saw, and then he'll come back in and he'll either agree or disagree with what we said, and we're going to do all of that in front of you so you can hear how the team thinks and our reasoning for things. And then hopefully you're leaving with a plan. You're not leaving with something nebulous, and with an insight into what your vocal folds look like, insight into what we think's going on, and definitely insight into what the treatments are going to look like and how long they should take. I hope that was comprehensive enough.
Yeah, I think you nailed it. And I think the discussion with the patient when I come in and we're all just kind of kicking the ideas around with the patient, I think that really appeals to them, seeing all the different sides, how we're thinking about things. Like you said, I think they like to see how the team is thinking, and people appreciate that this is a combined effort, right? And a lot of times, Edie, as you mentioned, there's options, right? I may say, hey, you can do this or that, or you may not want to do anything right now, but this offer's open. You can come back years later if you want to do the voice therapy or get this surgery we're talking about, very, very low pressure, because these are generally, elective kinds of decisions, elective medical decisions. But I think that team approach is what's really gets our results are I will say very good, because we work as a team, and I think that's probably what makes our success.
Great.
I love that. Dr. Simpson, this is for you. I noticed we had this as a question, and you both kind of touched on it, but I wondered if you could kind of explain in, simple terms, what helps us determine whether or not we want to do therapy first or do a procedural management? What are we actually looking for?
Yeah, it's a great question, because it's actually, I think, a big research interest of ours, if I think it's fair to say that, Edie.
Yeah.
Because how do we make these decisions? Because sometimes there's really no rules. That's the interesting thing, and I think our division here, the UAB Voice Center, this is one of the questions that we've been, I think, making some ground on. And we've discovered that those questionnaires that Dr. Hapner was talking about are actually helpful in ways of not just understanding how much it's affecting your life, but also we can use those numbers that come out, and almost in some ways we're starting to be able to predict a little bit better which patient, based on these numbers, would benefit more from an injection first, which would go to surgery. And no one's really ever reported that, to my knowledge.
Right.
So this is something we're trying to approach not only as an art, which I think is a lot of what we do in medicine, but as a science, as much as we can add science into this to make these decisions more clear. And that's been my impression, that based on how severe their vocal cords are lacking closure, is probably not the best way to say that, but we know the degree of closure of the vocal cords is probably very much related to that. And that's information we get from the video exam she mentioned and from the questionnaires. And we're able to put that together now and make a pretty reasonable determination who needs that injection and who doesn't. And I would say it's probably the minority that need the injection. Would you say that's fair, Dr. Hapner? Maybe 20%?
Actually, the study that we're hoping to get published, we're just waiting for them to say yes, actually found that, right? Like in aging voice, the majority of people go to therapy first and then procedure second.
Yeah, it's definitely a small percentage that need, the temporary and the permanent solution. It's a small percentage for sure.
Totally. Awesome.
It's about the best I've ever felt to feel worthless. The best situation I can feel.
I love it.
So let's say we're not doing procedural intervention, or we are, but we're also doing therapy. What does therapy look like? I mean, you went into that a little bit, but kind of give people an idea of what to expect, because I think sometimes when people come in for their first session of exuberant voice, they're like, what are we doing?
I know. Well, and how many times, Quinn, do people walk into the Voice Center and in one room we hear kind of loud productions of sound, in another room we hear some beautiful voice singing,
exactly.
And in another room, who knows. But so it's voice therapy, and I dare to say that voice therapy is fun. It is. Otherwise, I would not have been doing this for 44 years. I promise you. Dang, I just said that. Okay, for all that time. But voice therapy, generally sessions are about 45 minutes in length. And I already told you, you know, for most voice problems, we are talking 4 to 6 therapy sessions over 2 months max. We are still able to provide telehealth therapy. And I say we are still able because it's actually a law that allows us to, Congress decided to keep it for a little bit longer, at least another year, thank goodness. So insurance has to pay for both in-person and telehealth. And, you know, we learned a lot during COVID, and that is that we can get comparable results in many cases with telehealth therapy. So you're sitting in your house, we're sitting in our office, and we have good sound equipment, and we have methods to even analyze the voice when you're sitting in another place, and you know, doing therapy. We can do a hybrid, so a combination of both. And the only other thing I would say is, this is a shameful plug, okay, that at the Voice Center, we have clinicians, and this is mostly for a Parkinson's grant that we have, so, but it actually helps anyone. We have clinicians licensed to provide therapy in Alabama, Georgia, Florida, and Mississippi. So we don't have to ask somebody, can you drive over the border into Alabama like we used to have to.
Yeah, absolutely. And
That's
that
been a
makes
game
such a big difference. And I, you know, just say, come prepared to play around with your voice in therapy. Even if you are a quieter person, come prepared to have some fun and get a little loud. We actually had a question about singing voice, which I know we mentioned briefly before, but you know, we often have patients come in with aging voice complaints who are singers, and their singing voice has changed. I wonder, Dr. Hapner, if you can talk a little bit about what services we can provide in kind of conjunction for aging voice, and in particular, what we offer for singers as well.
I think I'm going to also, let me just start, and I'm going to let you finish, because Quinn has a master's degree in vocal performance, and she's an opera singer. You should hear her voice. It's beautiful. And she had a performance career also. And so now she's a speech pathologist. And actually, just FYI, and I know this is always a concern for people who sing, we have 3 speech language pathologists who have degrees in music, performance careers, and then decided to go back to school and become speech pathologists. And that is a very big commitment. We have so we have opera covered, and we have musical theater covered, and we have pretty much, you know, contemporary Christian music covered, you know, things like that, pop, rock, because of their histories. We also have another speech pathologist who does a lot of kind of folky kind of singing, think James Taylor, kind of singing in, and has a beautiful voice and is well versed in working with singers. So I feel like we can cover the gamut of the genres and have people that can, you know, I'm going to say it like this, talk the talk. So understand the lifestyle that you may be living, the pressures that you're under. And actually, I think we're pretty expertise at trying to keep people in their singing. We hate it when somebody tells us they no longer sing. We hate it. We're like, we got to get you back there as soon as possible. But maybe, Quinn, you speak to it because you are a singing voice specialist.
Sure. Yeah. I mean, I agree with everything Dr. Hapner said. I think sometimes we see patients who come in who they noticed it first in their singing voice, and they're like, you know, I've been singing my whole life. I've sang in choir forever, and my voice is just not the same. You know, like I can't move through my range as comfortably as I used to, or I don't have access to these notes. And those can all be things secondary to aging voice. And I like to talk to singers that, you know, it's nothing they did wrong, and that we just got to kind of learn to give them a little more power and work with what they have now, right? Because our bodies change as we get older, and there's nothing wrong with adapting to that change. But singing is actually an amazing way to address aging voice, like Dr. Hapner said, because it's an exuberant type of voice use. So myself and my colleagues who have background in singing really love working with singers of all ages, and there's a lot of stuff that can be done therapeutically to help. So no one should ever stop singing. There's no reason.
Don't ever stop singing.
Yeah. So, Dr. Simpson, I'll throw this. This is kind of like a wrap up. We've given people all this information, and there will be time to add more questions. So please, if you have questions, add them in the chat because we have about 10 more minutes. So I'd like to take more from the group. But with all these options and with these resources we've talked about, what happens, Dr. Simpson, if people don't do anything?
Well, I mean, again, we're going back to sort of this notion of these are elective decisions. There's a good chance if you come in when you're age 75 and you're having problems with your with power in your voice and fatigue, there's a good chance that's going to get worse as time goes by. I don't think it's going to be a rapid deterioration by any stretch. But I will tell you, the patients we see that are in their mid 80s tend to have more thinning of the vocal cords than those that are 75. Edie, you may know the science behind that better than I do, but I think the chances are pretty high that it's not going to go away and it's going to get a little bit worse over time. But you still remain a candidate for the therapy, as far as I'm concerned. The decision to make the therapy, that's why it can be made later. But things will probably get a little bit worse over time if not addressed. But you'll never lose your voice entirely. I mean, I just don't see that. It can get very soft, and you can get to the point that it's difficult to communicate where there's any background noise, but the voice should still be there in some form.
Don't you think that sometimes what happens is that any problems people had with their voice a little younger are almost amplified? A little bit is, because don't forget, if it really is aging voice, a person is walking in our office hopefully after a life well lived, right? So we don't expect everything to look perfect. It can't look perfect because life happens. And so I think some of it is just learning to efficiently adjust to those changes that feel a bit amplified because the vocal folds are thinner. And so as we build that system, the respiratory system, the phonatory system, then also helping you adjust to those changes that happened maybe 20 years ago, but just you could kind of work around then.
Absolutely. All right, we have some more questions in the chat. This one I really, really like. Dr. Simpson, I'll give this one to you. So how does how does vocal fold atrophy secondary to other things like intubation, trauma, or deconditioning due to an extended hospital stay? How does that differ in management from aging voice? Oh, you're muted.
Yeah,
Yep.
yeah, I was muted. I think it's really kind of reflects what Dr. Hapner was just saying. We see people with vocal cord paralysis, for example, where the vocal cord was completely paralyzed, but does recover over time. Let's just say maybe you had a surgery on your neck, the nerve was bruised, your vocal cord was paralyzed, but then it gradually recovers. And maybe even to the point that it looks almost normal. I think that person is much more susceptible to these age-related changes later in life, pretty much what Dr. Hapner was saying, than somebody who's just having routine aging. So yeah, if you add in anything that weakens the vocal cords from a nerve problem, anything that weakens the vocal cord from loss of muscle, I think, yes, as you age, that's going to be amplified and those problems become more significant. Whereas an otherwise normal system with thinning of the vocal cords will not be nearly as affected as much. And I know this just from having done this for 30 years, in that I would see people I'd successfully treat with a paralyzed vocal cord that would come in 20 years later, and they were having some issues that were usually related to aging voice. Right. Now the nice thing now, I might have felt like I had to revise their surgery, right? Put a bigger implant in to account for that thinner vocal cord. But the great thing now is a lot of times the solution to that is voice therapy. So, just because it was a surgical, a solution the first time doesn't mean it's going to be a surgical solution the second time. So these age-related changes can often be dealt with therapy instead of a return to the OR. And that's been really, honestly, of all the things, that's been one of the greatest things because no one wants to revise their work. Anybody has been a surgeon knows it's better to not do that. So this gives us many more options that we didn't have in the past.
Anything to add to that, Dr. Hapner? Don't want to. Okay, good.
No, except
Love
that
it.
he's so generous, isn't he?
Yes, I
love
know.
it.
Listen,
So
anytime you make a surgeon's life easier,
Oh, you're happy? Oh, there
so
you go.
grateful. We're so
Let's
grateful.
tell you what it's really about. Go ahead.
Yeah.
It's selfishness.
So this is another good one. This is regarding senior singers. So,
Yeah.
people with aging voice who are singing. And the question's asking about what you can suggest to these singers to help strengthen and stretch their aging voices, and do vocal warm-ups change as they get older?
So just a little caveat, Dr. Simpson said I moved here from LA, and there's an awful lot of encore careers that older performers in LA want to have, whether they're comedians or actors or singers. And so I feel like I learned a lot from having those years there working with them. So number one, I think that there's nothing more important than that warm-up, and probably cool down also. And that the warm-up is likely, you got to be careful because you've got to balance fatigue also. But the warm-up is gentle. It's about slow stretches of the vocal folds. Dare I go, woo, so a little bit more semi-occluded. If somebody, sorry, Caroline, I was peeking in the chat, so some semi-occluded vocal tract exercises. So you're slowly, like the stretches when we go to the gym, right? And you're working a bit with those joints that can, there's the same joints in your larynx that there are in your elbows and your knees. And so my knees crack when I get up these days, and sometimes even my elbows. So kind of getting the fluid and stuff out of there, but very gentle. Not fatiguing, but maybe a little bit longer, a slow build from kind of comfortable pitch to maybe like a crescendo and then back down, working with all levels, range and loudness in a warm-up. And then just helping, and I'll tell you what that's for. That is actually to help people unload the extra tension that they tend to want to use, especially in choral singing, right? Like you got to hear yourself, you got to work with the person next to you. Who knows if the person behind you's got a huge voice, right? It's learning that blending. And Quinn, what else besides that? Anything else that you want to add?
I think one thing additionally, that as people get older, they kind of lose their connection to their chest register, or their, TA dominant voice is what we call it. And especially older singers, especially, church choir singers who've kind of sung their whole life. So doing some warm-ups that really target that chest voice to remind people it's there and that they can use it. And, sometimes can get a little more bang for their buck if they're down in the lower part of their range. Try to be in that, nice full contact to your vocal folds to get a little better volume and efficiency. I think that's something we see frequently as especially older women, as it happens, who've kind of lost touch with their chest voice. So doing stuff like that as well.
Can I just make a plug for remembering that this little piece of real estate, your larynx that produces your voice, is part of a whole system, right? We are, it doesn't live by itself. It lives in the body. So one of the biggest problems with aging is frailty. And frailty is demonstrated in the voice more than anything else. So talking to your choir members about their diet, seriously, right? Like as we get older, we need more protein. I'm not a dietitian, but their diet, making older people tend to not eat as much. Exercise, socialization. If you're leading a choir of older singers, make sure you build in some socialization time, because boy, they really love that piece. And when we feel better about ourselves, when we are nourished well and we've slept and we do even some just light exercise, take a walk every day. Don't forget about that. Our voices are going to say, your voice is telling on you is the title of this presentation. But we know from so many studies that people don't have to say very much for other people to know how they feel. And so we want people to feel good, to sound good.
Absolutely. And one other plug, hydration, right? We know as we get older,
Good
our
plug.
mucus gets thicker. So you gotta keep it hydrated. Yeah, Dr. Simpson.
Good plug.
A personal sufferer of that. Yes, it's true. Hydration is so important as you get older. It really is. For our throat clearers, for our people that just feel that thick mucus in there, it's essential. It really is. And it's part of the aging process as well, unfortunately. I've come to find this out.
Well, that kind of concludes our time. One quick plug, this QR code on the screen is for our Instagram. We post resources there for patients and clinicians, pretty much anyone in our community. So we would love if you gave us a follow. We post fairly frequently. And then just a huge thank you to Dr. Hapner and Dr. Simpson. I hope everyone found this informative. I know I learned a lot, even as someone who gets to spend every day with them. But this was lovely. Thank you everyone for attending.
Thanks, Quinn. Great job.
Happy National Senior Citizens Day, right?
Yes, of course. I
Yes.
totally forgot, dropped the ball on that. But yes, happy
That's
National
right.
Senior Citizens Day. Thank you for celebrating with us and learning.
Thank you, Quinn. Bye.